Bismillahirrahmanirrahim. Assalamu alaikum, dear audience. I welcome you to another session of our International Ophthalmology teaching sessions. And today our topic of discussion is about the use of botulinum toxin in squint management. Squint surgery since years has been done by the mechanical correction, depending upon the sections, recessions, muscle transpositions, and later on, the botulinum toxin was introduced in the management, and that proved to be a paradigm shift. And now it is a cornerstone in the management of the squint surgeries. We are honored here to welcome our guest, international speaker from Turkey, Ankara, Professor Fatma Yolek. Professor Fatma Yolek did her residency from Turkey in 2000. Post-graduation in 2008, and after that she did her post-graduation in subspecialization from Moorfield Eye Hospital in pediatric ophthalmology and pediatric glaucoma. Later on, she also did her observation from Massachusetts Eye and Ear Infirmary, Harvard. In 2015 and 16, she did her clinical fellowship in pediatric glaucoma from UCLA, United States. She has also done PhD in biomedical engineering. We are honored that a scholar of her repute and experience has given us time and accepted our invitation to share her knowledge and experience about this very technical issue that is about the use of botulinum toxin in the management of squint surgeries. So without further delay, I will request Professor Fatma Yolek to please present her talk.
Thank you very much, Dr. Mirza. I'm thankful for your kind invitation. This evening, we will talk about use of botulinum toxin in strabismus. Let's start with a little bit physiology. The motor nerve endings close to muscle have acetylcholine to produce the signal for motion of the muscle. And the acetylcholine is released from the vesicles, and it causes a signal for contraction of the muscles. Botulinum toxin inhibits this acetylcholine release, and it causes some kind of chemodenervation and produces a flaccid paralysis of the muscle. Its maximum effect starts at 5 to 7 days and lasts about 6 to 9 months. Why do we use toxins in strabismus? It's a painless, inexpensive, quick, easy, and safe procedure, and it can be usually done without general anesthesia unless it's second. Toxins are effective for weakening the overacting muscle. If the fusion is present, it can stabilize the alignment even with a single injection. It can also be used at the time of surgery, during the surgery, and after the surgery. In some studies, it has been shown that it can be used with bupivacaine and can correct about 10 to 35 prism diopters of deviation together with bupivacaine. There are several methods of injections. The best one is doing it with EMG recording, a syringe connected to EMG recording to localize the muscle. And this is the safest route, in fact. Another route can be under direct visualization. After opening the conjunctiva, we inject just into the belly of the muscle. Or without opening the conjunctiva non-invasively, you can localize the muscle and inject inside the belly of the muscle. This is somewhat blind procedure, but it can be done safely with practice. So this temporary paralysis, how is the result becoming permanent? In fact, we don't know this exactly. The paralysis changes the eye position like a traction suture. The traction suture puts the eye in a position that we want. And this toxin provides us this position. The added sarcomeres lengthen the stretched chemodenervated muscle and produce some changes in the extraocular muscle. This can be one way. And another explanation may be the central adaptation, that is, restored binocularity and improved fusional vergence amplitudes with alignment of the eyes. Botulinum toxin is an important tool in strabismus. It has been used since 1970s, introduced by Alan Scott. And the dosage changes from 2.5 to 10, depending on the amount of deviation. You can use the EMG, or you can do without EMG, as I explained previously. And there is no limit on repeat injections. This is very important. It's an outpatient procedure and does not preclude surgery. You can do surgery anytime you want after the effect of the toxin fades away, or with the toxin, depending on the situation. It's especially suitable for restrictive and unstable deviations, as I will explain you with some examples soon. What about the diagnosis? This toxin is very helpful for diagnostic situations. For example, in intractable diplopia, we can use botulinum toxin to simulate the surgery and see if the patient has a diplopia after the surgery. It's especially important for the third nerve palsies with long-lasting deviations. Another use is to see if there is postoperative diplopia. It may simulate again surgery for the patient and observe if the patient will have diplopia after surgery. In paralytic strabismus or paralytic strabismus, there is restriction of the antagonist muscle. The antagonist muscle contracts in the case of paralytic muscle. And in these patients, we can paralyze the antagonist muscle to let the paralytic muscle to move and test if this muscle is functional. This time, it's again helping us to make a decision about surgery. And let's come to the therapeutic uses. As I said previously, it can be used in adjunct to surgery. This effect is sometimes permanent and sometimes not. And when it's not permanent, some repeated injections may be needed, but with increased intervals between these injections. So if the patient does not prefer surgery or the surgeon does not prefer surgery, but this decision is usually made together, we can go on with repeated injections depending on the situation. We usually use mainly for small deviations, but for larger deviations, depending on the situation, we can use it also. In infantile esotropia, there is a large meta-analysis study studying the effects of botulinum toxin. In this study, we have observed that with about 1.6 injections, 77% correction can be provided. In neurological normal infants less than 7 months old, the success rises to 88%. It has been reported that better response, about 60% success, is reported with deviations less than 30 prism diopters. When the deviation exceeds 30 prism diopters, the success decreases to 45 prism diopters. It is similar with surgery in infantile esotropia. But in cases where we hesitate to do surgery, we can use botulinum toxin in these cases too. As I said previously, the main indication is recent onset cyclic exotropia and accommodative esotropia in children especially. This is a kid who has been doing close work, especially during COVID pandemic. We know we have all seen these kinds of kids. Even in adults, we have seen these patients, these kinds of patients. After a single toxin injection, his diplopia and esotropia has improved significantly, together with some measures to restrict the near work. Also, in intermittent exotropia, the success rate is about 70% for botulinum toxin. We can augment normal strabismus surgery with botulinum toxin if there is a deviation about 70 to 100 prism diopters. Usually, we prefer to use 3 or 4 muscle surgery. But in order to avoid 3 to 4 muscle surgery, we can do 2 muscle surgery together with botulinum toxin this time. The botulinum toxin increases the effect of surgery about 42%. That's 4 to 5.7 prism diopters per millimeter weakening of the muscle. Other situations where there is muscle when the deviation is not stable, like the cerebral palsy or some muscular diseases, or ophthalmic problems like microphthalmia, we can use again botulinum toxin to be on the safe side. In transposition surgeries, in case of positions where we need more than 3 or 4 muscle surgery, we can weaken the muscle by toxin again to prevent anterior segment ischemia. So another use of toxin is pharmacological adjustment. What's it? It's a fine-tune after postoperative over and under corrections with toxin. The results are similar to surgery, but the effect is greater when the injection is done within the first 3 months after surgery. Let's give some examples. This lady had a residual exotropia, as you see here, after surgery. And we proposed toxin application. And she was much, much better with botulinum toxin. This young lady has a poor fusion, and she's a really difficult patient. She had consecutive exotropia. We did strabismus surgery. This time, she was overcorrected. She was esotropic. She was unhappy. But what did we do? We injected botulinum toxin to both medial rectus muscles. And after 6 months, she is ortho, and she is happy now. So these fine adjustments are easy with botulinum toxin. Another patient with residual esotropia, you see much higher esotropia here. As I said previously, with large deviations, its success is not that high, but you can have some better alignment, as you see here. This is 8 months after toxin. It has faded away, but it is better than the initial appearance. Adherence syndrome is important in some trauma cases or in some invasive surgeries. The fat adherence causes a restriction, pulls the eye to that side, and the muscle on that side should be paralyzed to put the eye in primary position. In primary position alignment, also in reading position alignment, we should prevent this contracture. For preventing this contracture, application of toxin is helpful. Another main indication is restrictive strabismus. Yes. Gentlemen with thyroid eye disease, you see the upgaze deficit in the left eye and contracted left inferior rectus muscle was paralyzed by botulinum toxin, and surgery was applied, and the upgaze was better with better alignment in primary position and reading position. We can prevent secondary changes in the muscle, but it should be applied early, especially in these restrictive cases. Another use is paralytic strabismus. Third, fourth, and sixth nerve paralysis. Here we can use it like traction suture again, and also supranuclear disorders like internuclear ophthalmoplegia. To relieve the diplopia and abnormal head posture, we can use toxin. This lady had a 6-nerve palsy, used the abduction deficit on the left eye, and with several applications of toxin, we could, we in fact prevented the increment of the deviation, and she needed also surgery, but we don't have to do transposition surgery. After 6 months, a small procedure together with toxin was enough to relieve her symptoms. This is an interesting patient with critical cavernous fistula. You see the abduction deficit here on this eye together with congestion and injection of the eye. 1 month after toxin injection, you see it is better. The patient is ortho in primary position and better on side gazes. But a little bit side effect here. Some ptosis has increased a little bit. And 1 year after, he's much better, you see. And it has just 1 toxin injection was enough for this patient. In post-traumatic strabismus cases, maintaining eye in primary position, like in adherence problems, is important. This poor gentleman had an endoscopic sinus surgery, and during this surgery, they have entered the orbit, from maxillary sinus to the orbit. The medial rectus was lost completely. The inferior rectus and inferior oblique were all injured. And he was a little bit exotropic, as you see here. The medial rectus not working at all. We explored, but of course, we couldn't find the medial rectus muscle. And we just injected botulinum toxin to the lateral rectus muscle. Several injections were done with 3 to 4 months apart. This is 20 days after first injection, and this is 1 year after. We can just have a primary position orthophoria here. He can't look inside, but primary position this is in fact a surgical success for this patient. He didn't need surgery. Just with toxin injections that had been done early enough. This young boy had a dystonia and acute onset esotropia. In fact, we were reluctant to do any surgery because he had some muscle problems, and he was hard to operate. And this was an unstable deviation. So we decided to do injection to the medial rectus muscle. 3 months after injection, he's ortho again, as you see here. In these unstable conditions, toxin is very helpful for both the patient and the doctor. Another important indication is these microphthalmic eyes with multiple surgeries. Both the patient and the doctor may not want any more surgery. In these patients, before they start to use cosmetic contact lenses, the primary position alignment can be achieved with toxin applications. As I have mentioned previously about the diagnostic uses of botulinum toxin in motor fusion deficiency, acquired motor fusion deficiency, it has also been reported in the management of acquired motor fusion deficiency, interestingly, in this lady. And just with 1 toxin injection, complete success was provided, and it has been reported as a case. And what are the complications? As I said previously, ptosis is the main complication. It is dose-related, temporary, and more with medial rectus injection. Spread to the neighboring muscles may cause vertical or horizontal diplopia depending on the affected muscle and injection. Other less reported problems are tonic pupil, accommodative deficiency, retrobulbar hemorrhage, and scleral perforation. Luckily, this toxin is non-toxic to retinal tissue. So when should we consider botulinum toxin mainly? The main indication is cyclic deviations and recent onset esotropia in children. But acute phase paralytic and restrictive strabismus, early stages of over and under corrections, early adherence syndrome can be other important indications. Additionally, for large deviations, it can be added to the recessions, and it can be used for evaluation of intractable diplopia and central fusion disruption. Also, recurrent deviations after multiple surgeries can be another important indication for botulinum toxin use. Thank you for your kind invitation again.
Well, Prof. Fatma, it was a very informative presentation in which you highlighted its mechanism of action and its uses and its practical applications. I feel that it will be very beneficial for our audience, our fellows who are doing training, and it will add to their knowledge. Just a few things that you, as you have got extensive experience in squint management, neuro-ophthalmology, and pediatric cases, Prof, how do you prepare this botulinum toxin in your clinics? And what about its refrigeration to maintain its efficacy?
I usually prepare with saline solution. There are clinics that use also, in addition to saline solution, some anesthetic solutions, but I usually use only saline. And the dosage for preparing the solution, I usually prepare it with 2 cc of saline with 50 units of toxin. And then the dosage depends on the amount of deviation. After preparing, I usually preserve it in the refrigerator, not in the freezing compartment, but only in the refrigerator for about 15 days. In 15 days, I can reuse it.
Right.
And during preparation, it's important not to damage the toxin. You just gently mix it.
Right.
And it's in addition to cold chain.
Prof, while applying these injections, what are the important precautions to prevent the complications?
Yeah. Thank you for this question. The main complication is ptosis and diffusion into nearby muscles. The ptosis is usually more prominent when the patient lies after the injection. So when we do the injection, even under general anesthesia, if it's a baby, I tell the parents to hold the baby straight with the head straight, not lying down, okay? Because when the baby lies down for a long time, with diffusion, it may go to the levator muscle and cause ptosis. So I advise them to hold the baby straight with the head straight on their shoulder as much as possible. And for adult patients, again, I advise not to lie, especially for the first 5 to 6 hours after the procedure, and to avoid hot water, to rub the eye, because by rubbing it may cause diffusion around it. And during the procedure, we apply cotton tip applicators on the 2 sides of the injection site for some time to prevent its diffusion to the nearby muscles. An important precaution for prevention of diffusion of the toxin is not to prepare it with much saline. Therefore, I don't use 4 cc. I usually use 2 cc to give a small injection to produce the larger effect without diffusion to the nearby tissue.
Thank you, Prof. Prof, one thing more, you mentioned using this injection under EMG guidance. If we have to go it without EMG guidance, what are the important steps, advice and guidance for the proper localization of the muscle? How we can do it without EMG?
Thank you very much. We can visualize the muscle under the conjunctiva, to make the conjunctiva white, we can use some drops like metformin and so on, or adrenaline drops can be used. After whitening the conjunctiva, it's easy to observe the muscle, and just you after observing the muscle, you can just inject over the muscle. This is one way. Without observing and visualizing the muscle, you can't do it blindly, in fact.
Right, Prof. Prof, usually we know that outcomes of squint surgery we measure in prism diopters, how much success, how much residual, these things after squint surgeries. But if we talk about the functionality, functional results, I'm talking about binocular single vision. How do you see its efficacy in maintaining the binocular single vision? And I can put forward also one thing, in which patients you will usually avoid the use of botulinum toxin?
Thank you. The results of surgery depend on the vision of the patient. In fact, the vision is our best friend. If the vision is not good, we should align the patient in ortho position as much as possible. And for this fine-tuning of this deviation, the toxin application is our friend. The healing process is not the same. Although the strabismus numbers have been provided from several patients, we can have some unexpected results. And for these fine adjustments, we can use botulinum toxin, as I told in my presentation. But when should we avoid this toxin? For large deviations, I usually tell the patient about toxin, but I don't advise. Because for large deviations, we should do several injections. I have been to Moorfields Eye Hospital while Dr. Lee was living, and I have observed patients with 40 prism diopters of exotropia, and they had no surgery, but they had about 25 injections. That's a huge number. For these large deviations, usually I don't recommend. Surgical correction with these large deviations is easier, but after the surgical correction, if there is a residual deviation that we don't want, we can fine tune with the toxin. But for larger deviations, I usually don't recommend it.
Right, Prof. Prof, one thing, when we talk about the management, there are so much expectations from the patient side. We know that this is a recommended treatment, but it has temporary effects and repeated injections are required. How do you see and manage these patients' expectations from this treatment modality?
Normally, for small deviations and for unstable positions, like I have explained, like patients with dystonia, cerebral palsy, with muscle problems. In these kinds of patients, the strabismus numbers are not so reliable. In these kinds of patients, I talk with the family and describe the problems with surgery and propose toxin application initially. As I said previously, this toxin application may provide us a treatment and also a diagnostic procedure for some patients. For example, for intractable diplopia, for patients with long-standing strabismus who may have diplopia after strabismus, we may simulate the surgery with toxin application. Our goal is not high with toxin application. I usually say to the family and the patient, let's see how will you feel with the simulation. It's like a simulation. I usually explain them like a simulation. And after that, if the effect is long-lasting, we are both happy. But if it's not, I tell them it may be long-lasting or not. We will see together. But if it's not long-lasting, you will see the effect of surgery. And after explaining everything to the patient, we can decide this together. It's important to discuss all these points with patient and the family.
Well, Prof, it was a very informative presentation, and you answered our questions also in detail. And I believe this presentation will be very beneficial for our residents, our international audience, people who are doing fellowships, and pediatric ophthalmologists. It will add your experience and knowledge to their knowledge and their management. It will be a great contribution. And I want to thank you on the behalf of our international audience who will be watching you and getting benefit from this discussion. Thank you, Prof. Fatma. And we are looking forward to more presentations to guide our audience about pediatric ophthalmology cases.
Okay, it's my pleasure. Thank you for your kind invitation.